Hi, everybody. I'm Ann Schaeffer. I'm one of the faculty members here at Eastern Mennonite University, and congratulations as you start your DNP. This is really exciting, and about 2 years ago, I was sitting where you are now. I just finished my DNP in December and through Frontier Nursing University, so I know what it's like, and congratulations as you embark on this journey. What I'm going to do is give you a short presentation today of my own project. This is not my final project presentation, sorry, technical difficulty, but it is the one that we were required to give as we completed our implementation, and it is not the one we did at the end of our dissemination. So I hope you enjoy it, and I'm going to screen share with you at this time so I can take you through it. Okay. All right, and let me just get it to the beginning. Okay. I want to point out that you are going to see a couple of abbreviations in this project that you may not yet know the meaning of. So SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. And I'm going to talk a lot about the PHQ, which is a brief screening tool for depression. Okay, so this is my project on improving the efficacy of depression screening for the Harrisonburg Community Health Center. We are located in the central Shenandoah Valley. This is a refugee resettlement area, and therefore we have an incredibly diverse community. Even though my specialty is women's health, my center's QI priority was to improve their depression screening and follow-up rate, which had been quite low for some time. Therefore, I found myself designing a project on depression and arrived at the aim to increase the efficacy of depression screening through SBIRT for screen-positive clients to 75%. And I needed to do this for a diverse, multilingual community. For planned changes, I needed to engage my team. I planned in-services, multidisciplinary planning meetings, held a contest to name the project, posted project updates, and shared patient stories. Teams also engaged in self-evaluation throughout the project. I wanted to engage patients in shared decision-making, and my team chose the option grid as the brief intervention tool to use. A great team of interpreters translated it into Spanish and Arabic. Later, warm handoff education for patients was added to the tool, also in 3 languages. At HCHC, the PHQ is administered verbally, but an interpreter shared her concern that asking the questions aloud is often not culturally appropriate and may be resulting in false negatives. I plan to trial written PHQs in 6 languages. These were organized in the so-called blue books and placed in exam rooms at the point of care. Finally, a right care tracking log was created, and patients who consented were entered for follow-up. Chart audits, follow-up phone calls, and data on follow-up was collected to guide best practices. I predicted that over 90% of staff would receive education and teamwork scores would increase by 20%. For patients, I predicted that shared decision-making and documentation of choice of care plan would reach 80% and that appropriate depression screening would reach 90%. Finally, I predicted that at least 70% of patients would have documented evidence-based plans of care and that compliance with follow-up would increase to 70% or more. In terms of results, I'll start with my aim, which was met, even achieving 100% on a few clinic days. To meet the aim, a patient had to be appropriately screened as positive on the PHQ. They had to have documentation of shared decision-making and an evidence-based plan of care, including a plan for follow-up. So how did we get here? Over the course of the project, 94.1% of the staff received training and education on depression screening, surpassing the goal. But working around summer vacations and staff turnover was a challenge, which also caused a drop in the teamwork evaluation scores, and ultimately a 20% increase was not achieved. Meet Nellie and Laura, 2 clinic staff. They have stopped in at a breakfast to celebrate the project halfway point. This provided an opportunity to educate and update the team and provide them with SMILES trigger cards, a new screening trigger. Both providers in this project became successful in documenting the patient's choice of care plan, surpassing the goal and even reaching 100% on several occasions. What made the difference was creation of a positive PHQ template in eClinicalWorks, which is our EHR, and this prompted quick and correct documentation. Our population has many risk factors for depression: refugee or forced immigration status, lower SES, and other chronic illness diagnoses, especially diabetes, anemia, and asthma. So I was not surprised to find that the positive PHQ rate in our clinic is not actually the 16% from the baseline data, but closer to 50%. One challenge is that halfway through this project, the care coordinator abruptly resigned. Until new processes were put into place for pre-visit planning, a drop in the rate of identified depression was observed. Starting in cycle 2, PDSA cycle 2, chart audits were conducted on kept follow-up contacts. Using guidelines from the U.S. Preventive Services Task Force and the CCNC toolkit, providers were documenting right care for patients most of the time, but compliance with follow-up had a baseline around 40%. This outcome was able to be increased to 60 to 80%, and it was continued to be tracked for 4 weeks after the project concluded. A deeper look at the tracking log data showed that about 68% of clients consented to be followed up. Of these, almost 16% were able to transition out of follow-up due to complete remission of their symptoms. This is a small number, but it's encouraging given the relatively brief length of the project, and we hope to see that number increase over time. To summarize, the timely screening of depression revealed increased prevalence in this population. Intentional patient engagement seemed to improve screening and follow-up and probably resulted in faster remission of symptoms. Team commitment was consistent throughout the project, although sometimes challenged by staffing turnover and summer vacations. But overall, we were able to meet our project aim. During this project, I learned that screening drives chronic illness care. When the screening rate dropped, fewer patients with depression were identified, and therefore fewer received appropriate referral to treatment. I learned perception of effective teamwork is affected by daily variation in staffing and pre-visit planning. And finally, when patients are engaged in their care in culturally appropriate ways, improved compliance with follow-up and remission of symptoms is more likely to occur. In terms of impact on the system, depression is much more prevalent than previously thought for the entire community and needs to be screened, treated, and managed like any other chronic illness. This project demonstrates that multidisciplinary teams can bring about great change. This implementation can be used as a model for other primary care settings, a model within HCHC for care coordination, and should help grow the behavioral health services at HCHC. In conclusion, it is promising that the screening process, understanding of right care for follow-up, and the use of shared decision-making have all been improved for 2 care teams. With coaching and resources developed by this project, other care teams at HCHC can begin to implement right care for depression. Tracking for positive PHQ patients should continue, but will benefit from an eventual transition to an electronic method that works with our EHR. As I reflect on this project, I realize I've come a long way since the last time I was a Frontier student. I also know that the faith that HCHC had in me as a DNP leader enabled me to take on this project and succeed. I have become a huge fan of multidisciplinary teams. For example, the internal name for this project was chosen by a billing assistant, the SMILES Project, which stands for Screening More Individuals, Less Emotional Stress. I strongly believe that when everyone on the team is engaged, great things can happen. When I began this project, I could not see the path ahead, but my site believed in me and I believed in my team, and now I know that we are prepared to take better care of those in our community who are the most vulnerable. Thank you. Okay, so that was my project, and it has since been accepted for presentation at not 1, but 2 conferences, and it's currently submitted for publication in a journal as well. So best of luck to all of you, and enjoy. It's quite a ride. Take care.